Okay, hi, this is Dr. Purcell. Let's do a quick review over the assignment in the EHR tutor that is for the patient receiving anticoagulant medication. I'm looking at Helen McCloskey on my screen. On the right side, I have the lesson, which I'm not sure if you're aware, you can collapse that and expand it. I just did this on the right side. I can get it out of the way so I can see everything, or I can open it up and see the questions. Excuse me. So we land here on patient summary, and this page presents us with a summary of vital signs, allergies, her orders, etc. But the first question that's asked is, what is the purpose of the continuous infusion of heparin? The other part of that question is it for prevention or treatment? And explain. Well, I don't really know anything about Mrs. McCloskey yet. So I'm going to come down, and the word notes is not highlighted. That tells me there's nothing in that section. So I'm going to come to S bar. This is the handoff report. So I hope to find out some information here about Mrs. McCloskey. I'm going to collapse that side so I can see this a little bit larger. So there's two S bar reports here. One is from the 11th at 7:30 and one is from the 13th at 7:30. So they're 2 days apart. The first one is from the PAC-URN, the post-anesthesia care unit after surgery, to the unit, to the floor nurse. And it's the transfer handoff. And it says, Helen McCloskey, an 85-year-old white single female, admitted with a fractured right hip. Her history, she has a history of degenerative joint disease, hypertension that's controlled with Lasix. Another word for that is furosemide, and toprol, or also known as metoprolol. The patient had an open reduction and internal fixation of the right hip with general anesthesia, approximately a 500 milliliter blood loss. 1 unit of packed red blood cells was administered in the PACU. She's awake, alert, oriented ×3. Her dressings are dry and intact. She has a hemovac with 100 milliliters of bloody drainage, plus positive pedal pulses. Her toes are warm and movable. So we're talking about her lower extremity because she had a fractured right hip with a repair. So we want to know if blood flow is and nerve conduction is good down from the hip to the toes. So that is why the RN is giving that information. So the positive pedal pulses, toes are warm and movable, 1+ edema to the right foot, IV in her left forearm, a liter of 5% dextrose with lactated Rayner's is going at 100 cc's an hour. She has a fully draining at 200 milliliters, clear yellow urine. The monitor shows normal sinus rhythm, and it lists her vital signs. She's afebrile, pulse ox is good for post-op. Now let's come and look at the one that's more current for you, and it's the night shift reporting off to the day shift. Okay, Helen McCloskey, an 85-year-old female. She's post-op day 3, from an open reduction and internal fixation to repair a right femur/hip fracture. Her vital signs have been stable. Her surgical site is clean, dry, and intact. She still has a hemovac drainage with scant drainage in it. It'll likely be discontinued today. Her Foley was discontinued yesterday. She's voiding well. Her lower extremity pulses are +2 bilaterally. Her toes are warm and movable bilaterally. Approximately 1+ edema to her right lower extremity. IV to her left forearm with heparin infusion running. She experienced increasing pain and swelling of the right calf yesterday and was diagnosed with a deep vein thrombosis. Was started on heparin therapy as follows: 6,000 units IV, followed by a continuous infusion of heparin. She's to get 20,000 units a day. She has orders to start on warfarin today in anticipation of discharge in about a week. Let me go over that again. So she was started on heparin therapy and was given a loading or first-time bolus dose of 6,000 units to get her anticoagulated quickly but safely. After that, they started a continuous infusion, an IV that's continuously infusing into her body. And it's heparin, and it runs at a rate that gets her 20,000 units a day. She's going to start oral warfarin today in anticipation of discharge in about a week. Recommendations: review your orders for warfarin, review your AM labs for coagulation levels, monitor and reassess. So I'm going to click expand so I can go back and look at my questions. What is the purpose of the continuous infusion of heparin? Well, we now know she has a deep vein thrombosis in the right calf. That is the reason she is on the heparin. So the next part of that question is this for prevention or treatment? Well, we know that anticoagulants, especially heparin, can be given to prevent issues, and they're given at lower doses in that case, or to treat issues. And in that case, they are given at higher doses. Well, she has a problem. She has a deep vein thrombosis. So she is getting heparin for treatment. So question 2, what data are used by the nurse to evaluate the patient's response to heparin therapy? So we want to know if she is anticoagulated. We want to know if the heparin is working. And at this point, assessing the right calf, the DVT, will provide us with very little information as to whether or not the heparin is working. One thing it might provide us is if the DVT were to become noticeably larger in size, that we could see that would mean it's not working because she's continuing to make clots. So we need to know if she is anticoagulated. So what I'm going to do, collapse that, I'm going to come over here, I'm going to find her laboratory results right here, labs. And I want to make sure I'm looking at the most current labs. You have labs from October 10th, 11th, 12th, and 13th. I want the most current, which is going to be the 12th or 13th. And along the left, I'm looking, there's hematology, blood type, A1C, chemistry, lipid panels, coagulation. There we are. Remember, the far right is my most current labs. So I'm going to look at the PTT, the prothrombin time, and her INR. And there's supposed to be a way to see what their normal values are. It's in another part of the EHR. I'll show you in a moment. But I can see over the course of these days, her PTT has gone up from 37 to 48, and her INR is from 1 to 1.1. And they probably want her a little bit higher, but I can see that there is a drug working. This is a therapeutic effect of heparin. So that's the answer here. What data am I going to use? I'm going to use the coagulation labs. Now, number 3, the order for heparin is 20,000 units daily, which means the IV infusion must deliver this dose over a 24-hour period. And note that her heparin comes up to the unit from the pharmacy in a bag with 25,000 units in it, which is not very wise. You would think that now we're going to waste 5,000 units probably at the end of 24 hours to put up a new bag. But pharmacy, it'd be nice if they would make it in a 20,000 bag. So you're going to go into her room and see a bag of heparin, a bag hanging, an IV fluid bag that says 25,000 units of heparin that has been put into dextrose 5%, 250 milliliters. So 25,000 units of heparin might actually only be like 10 mLs total volume. And it would be very hard to get 10 milliliters to go over 24 hours. that would take, I mean, you're just holding a 10 ml syringe for 24 hours. So since it has to go over 24 hours, a continuous infusion without interruption, they put the heparin into fluid. So it's put into this dextrose 5%, 250 mLs. And if I want 250 mLs to run over 24 hours, I can do that math. You take 250 divided by 24. And so that would give you 24 hours. And generally, these days, to prevent errors in calculations, that is how it's going to be ordered. And like it would come to the unit, 20,000 units would be in a bag with 200 milliliters of dextrose instead of the 250. It helps keep the calculations simple. And I asked, will the infusion bag last? And it will. It'll actually have a little extra in it, which is fine. You throw it away and put a new bag up. We don't usually let anything run for more than 24 hours without changing to a new one. So how many milliliters per hour would deliver a total of 20,000 units in 24 hours? And I don't have that math in front of me, so I don't know the answer right off the top of my head, but I could work it out and do that. And I can actually post that in our module, show you the math of how you do that, because we haven't started doing milliliters per hour yet. So don't freak out if you can't do it. But there's a chapter in your Turner textbook called, and it's on anticoagulants, and there's a chapter on calculating doses of IVs. But in your chapter on anticoagulants, it will show you how to do that calculation. Okay. Oh, you know what? Let's do a little cheat and see if it says on the MAR, if it has it on there. Let's collapse that. We have cefazolin, doxyheparin. Let's see what our heparin order looks like. It's not letting me tick it. Okay. So we have 20,000 units and 250. And it just says the dispense. I'm not sure why I have to click over here in one of these. There we go. Please wait. Okay, we're waiting for my super fast internet. There we go. No, there we don't. Oh, here, scanner not working. Okay. Okay, it does. Oh, so they did not do the math for us here, where they would normally tell you how many mils per hour that you would need to set on the pump. Your hospitals will. I'll tell you, this is such a high alert drug that and actually this takes 2 RNs. You need another RN to check it off with you before you hang it to make sure that you've both done the math correctly for this patient. But let's look at number 4. The patient is to begin warfarin this morning. What is the reason for administering heparin and warfarin concurrently? Well, the reason is that warfarin takes several days, 5 to 7 days, to actually have a therapeutic level in the blood where you will see that it's working. And at that point, you can take the heparin away and just the warfarin will work. But if you start warfarin and stop the heparin, you don't have enough anticoagulation. And we're going to increase the problems associated with the DVT. So she's on crossover therapy. She's on heparin while we wait for her warfarin to build up in her bloodstream to a therapeutic level. And then number 5, before discharge, the nurse reviews the patient's use of over-the-counter medications and notes that Mrs. McCloskey uses aspirin for headaches and various muscle aches. What will the nurse discuss with her about this medication? Well, aspirin is also one of our coagulation modifiers. It's not an anticoagulant, it is an antiplatelet, but it modifies coagulation. It works on the platelets, not in the cascade, but on the platelets for the life of the platelet. So if she takes aspirin, she could actually become more anticoagulated than the therapeutic level and could experience bleeding. And the bleeding we worry about is spontaneous bleeding in the brain or the GI tract. So the nurse will counsel Mrs. McCloskey to not take aspirin products or anything that contains aspirin or NSAIDs like ibuprofen. And what she can take if she has aches and pains or headaches is just regular acetaminophen, not Excedrin. Excedrin has aspirin in it. Acetaminophen itself is safe for her to take. So that takes us through her chart. I clicked on home medications. I believe that is where we see there's the aspirin. And flow sheets would show you her vital signs if you wanted to look at her vitals and see how she's doing. And it would give you, it's nice to note, again, always look at the top, what direction time goes on your flow sheet. Is it going from oldest to newest or newest to oldest? Because you can look at another sheet. Let's just do this. I think it's on the summary. Sometimes that one was oldest on the left, newest on the right. And sometimes it goes the other way. Let's find this lab one. Yes, see right here for labs, the newest is on the left and the oldest is on the right. So always orient yourself to what you're looking at, even within the same chart, because here I am looking at labs. The newest is on the left. If I go up to the top where it has vital signs, the newest is on the right. So that's just a little hint and an important thing, actually, when you're looking at medical records. All right, I hope this was helpful and I appreciate you listening and happy studying.